diabetes.
Respected Chief Physician, Dr. Krishna, Dr. Patnaik, Dr. Senukku, Dr. Vasurai, Dr. Jha, Dr. Roy, Dr. Samantrai, and friends. Today I am going to discuss one case which was diagnosed radiologically in our department, though it was a medical case. So I just want to illustrate how the diagnosis we reached step by step through radiological investigations. He was a male patient, 40 years, from Howrah, attended casualty with acute headache for last 3 days. He was admitted in casualty. His condition was not improved even with lots of medication. Then he was shifted to ICU for management of headache. He was a chain smoker, history of taking 20 cigarettes every day, no history of hypertension, diabetes, and no recent history of fever, chest pain. Mentally, he was a very sound fellow. He was a businessman, having average income, having appreciable social welfare attachment. He is also donating blood in every year. A very humorous fellow. On examination, what was we found in casualty, his BP was 170/100 the first occasion, pulse 80 per minute, ECG was within normal limit, vision myopic normal, chest bilateral normal, vesicular sound, CVS was also normal S1 S2, and no murmur also heard. For abdomen it was soft, no ascites, no organomegaly. Investigations we actually I have not directed the investigation. We got the part of the investigation part, the radiological investigation part. Though he was investigated hematologically, radiologically, and also the cardiovascular system. As per his history sheet, hemoglobin was 13.3 milligram percent, urea 27 milligram percent, creatinine 1.4, little bit high. Fasting blood sugar 105 milligram per DL, and ppbs was 211. It was borderline. His HbS C1 was 6.7. I have not mentioned here, but he found he was diabetic. Sodium 135 millimole per liter, potassium 3.5 millimole per liter, cholesterol 142, HDL 45, and LDL 72 milligram percent. Radiological investigations, he was directed for X-ray chest. It was absolutely normal. There was normal parenchyma. Dome of diaphragm was normal. Cardiac salutes normal. No mass lesion, no metastatic lesion seen. Then USG, whole abdomen was also prescribed. Then Doppler, bilateral renal arteries. Then CT scan of brain, ultimately renal artery angiography. We have done the CT scan was done. Sorry. CT scan of brain done first, and there was a report. We got the report. The cerebellum appears absolutely normal. Brain stem was normal. Fourth ventricle normal, and it was in midline. Third ventricle and the lateral ventricles also normal. There is no ventriculomegaly. Basal cisterns also normal. Sella and suprasellar regions also normal. There was no midline shift and no mass shift. The impression of the CT scan was normal study. just to rule out the malignant intracranial tumors like glioma, oligodendroglioma, then microglioma, the CT scan of brain done, and the normal report also ruled out the meningioma, neurofibroma, pituitary adenoma and colloid cyst in the brain. So further investigation was recommended. Cardiovascular studies, ECG done, it was a sinus rhythm, no ST changes found, echo, LV size, left ventricular size normal, good LV function found, all valves are normal, pericardium found normal, and left ventricular ejection flow also 73%. It was within normal range. USG whole abdomen then recommended. USG whole abdomen, his gallbladder was free, liver size normal, spleen normal. What we found a significant change in the size of the kidney. The left kidney size found a little smaller than the right side. Usually we get the size of the left kidney is little bit larger and slender compared to the right side. But there was no particulomedullary changes. It was absolutely normal. No hydronephrosis, no hydroelevator, parenchymal vascularity apparently found reduced in the left side, but it was almost in the normal range. So only the significant change we found in the normal in the USG of whole abdomen, that size of the left kidney little bit smaller than the right side, which is abnormal in radiological point of view. Then Doppler renal artery is done. The Doppler of the renal artery found the right renal artery Doppler spectral presentation was absolutely normal, that is peak systolic followed by a slow diastolic to the base. And left renal artery Doppler presentation was completely different. It was perverse status type of wave formation. That means the systolic piece is grossly reduced and dampened, and simultaneously reduction of the diastolic flow volume and the flow pattern. Sir, this is a normal flow pattern of a kidney, right kidney, the renal artery of the right kidney at Hyla. There is a peak systolic flow followed by a slow diastolic flow, and again there is a peak systolic flow. This flow pattern is very much important to see whether there is any narrowing, whether there is any stenosis, whether there is any plaque, and whether there is any compromised blood flow in the kidney. So the right side, right renal artery found absolutely normal at the Hyla. Sir, this is the flow pattern of the left renal artery at Hyla. You see there is a no peak systolic flow. Its flow pattern is appears like a monophagic. Venous flow appears like this, a monophagic. There is no variation, no change, no peak systolic spike, and there is no followed by a slow and dampened diastolic flow. So this flow pattern raise a question whether there is a stenosis or not. Sir, this is a photograph of a normal renal artery Doppler. It is taken previously. So there is a, you see, you can appreciate very well that there is a peak systolic flow followed by a slow diastolic, and again there is a peak systolic flow. This is a Doppler of a transplant kidney. You see, after transplanted kidney, we often examine in our setup, and we also give the opinion regarding the flow pattern, flow velocity, and the resistivity index of the transplant kidney also. So this is also normal. But the left renal artery in HILA again examined in a separate occasion, because once we get a abnormal Doppler presentation or Doppler reports, we used to review it for thrice, 5 times, 10 times, so that before we getting satisfactory result, we cannot declare that there is a stenosis or narrowing. So this is another picture of that patient, was taken in the same sitting after half an hour, and we got such type of flow pattern. There is a dampened systolic spike and very narrow diastolic, followed by a very narrow diastolic flow. First we examine the renal artery at HILA region, then we go for the vascularity of the parenchyma of the kidney, then we go to examine the renal artery from the origin, that is right from the abdominal aorta. So this is a picture of left renal artery arising from the abdominal aorta. So this is centrally this colored area, orange color area, this is abdominal aorta, and the cursor is placed over the left renal artery. And we can appreciate that there is a peak systolic flow and there is a loss of diastole. This is a peak systolic flow and there is a loss of diastole. This peak systolic flow, loss of diastole. This loss of diastolic flow signifies that there must be some stenosis near the renal artery. Again we repeated the case and we found the same type of spectral presentation of the renal artery in the left renal artery at the origin, that is from the abdominal aorta. So this was the first study done in our setup, the renal artery Doppler. The peak systolic velocity of the right renal artery was 45.17 centimeter per second, and if we compare with the left side, the peak systolic velocity was 23.31 centimeters per second. Almost 50% flow velocity reduced in the left side compared to the right. And ultimately, you can appreciate that the resistivity index at last, it was 0.5. So resistivity index of renal artery is very important. If there is a compromised flow, even in study of the transplant kidney, the resistivity index should be within 0.6 to 0.7. If it crosses 0.9 or 1, it is a high resistance. That signifies definite stenosis or narrowing or compromised flow. So the right side we got the resistivity index 0.5 and the left side we got it was 1. And the end diastolic flow almost same, because the end diastolic flow it is a velocity just compared to the venous flow, that is less than 20 centimeter per second. It is normal in both cases. So this peak systolic velocity and the resistivity index are very important features in the renal artery Doppler study. So from the Doppler study we concluded that there is a reduced flow in the left renal artery and there must be some narrowing or stenosis. But we cannot find out the location of stenosis, whether it is near to the abdominal aorta, whether it is in the mid position of the abdominal aorta and the kidney, or whether it is at the HILA or inside the HILA. So further investigation required. The patient was then referred for MR renal angiography. The abdominal aorta, the report is like that: abdominal aorta is normal in course and caliber, no focal area of stenosis or aneurysm seen. Left renal artery shows a focal tight stenosis in its proximal segment. Right renal artery appears normal. Left kidney is slightly small in size as compared to the right, and it shows poor excretion. Right kidney is normal with normal excretion pattern. The impression was the features suggestive of left renal artery stenosis, and 80% less perfusion seen in the left compared to the right. That was the impression we got from MR renal angiography. So this is the photograph of MR angiography of the renal arteries. You can appreciate that there is a sudden narrowing of left renal artery before after the onset. So this is the right renal artery, this is the left renal artery. You can appreciate there is a sudden narrowing just after origin of the left renal artery. So the MR angiography almost supported our findings in Doppler study. The diagnosis given by them was a left-sided renal artery stenosis supported by a renal artery angiography, and DTPS can also done for the patient, and there was a loss of perfusion, loss of function of the left-sided, partial loss of left-sided kidney function found. The treatment, left renal artery stenting and release of the stenosis. He was treated in Vellore, and so after treatment the patient again came back, and that is the beauty of Doppler. Again we found the normal flow pattern in this left renal artery, which was released operatively. So if you can remember the previous picture, there was a no peak systolic flow velocity, there is a monophagic flow pattern, reduced diastolic flow.
Back कर भी देखो सेटा.
अच्छा. Sir, it was the previous picture, and now after post-operative correction of the stenosis, we got this was the observation in our setup. So the patient improved a lot, and his blood pressure also improved compared to the previous days. I will give you the results. This is the left renal artery at hilar, almost normal flow pattern type. The patient revived. So it was previously the peak systolic velocity was 23.3 centimeter per second. Now after release of stenosis in Doppler, we got the peak systolic velocity. It is 53.39 centimeter per second.
ଭଲ डॉक्टर पटना बोलছি